here at Baylor University Medical Center here in Dallas, Texas, and we wanted to kind of give an update on the physical examination. You know, the anatomy continues to progress, and our understanding of the pathologic anatomy continues to evolve. We wanted to show you basically what the physical examination consists of today in 2014. It's basically the way it was when we first did the test at Stanford, but there's been some additional testing we think that's important to add in your basic examination. So this is Jane McDonald. She's our nurse here at the clinic, and she's happily assisting us today with the examination. So Jane, we're going to play like you have hip pain on the right side, and we're going to examine the right hip. So stand up and show me if you had hip pain where it would be, and it's there. So the first thing we do is come into the hallway, and we'd have her just walk down the hallway. And the first thing we look at here is we look at the stride length and the foot progression angle. Her foot progression angle on the right side is 5 degrees external. And as we come back, we see that the arm swings and the knee is aligned. Her foot progression angle is about 5 degrees external with equal stride length and normal arm motion. So as we come into the room, we want to screen first for any type of laxity. So we check here for the bright signs. And there, yep, that's good. And so we want to look at the shoulder heights, make sure they're symmetric, leg lengths are equal. Those are perfect. Let's have you turn and face the wall. Let's have you bend over and touch your toes. That's good. Check the spinal alignment. So okay, back up straight. And we just kind of check for side bending, kind of screen the SI joint and the back from that part of the examination. And we'll have you turn and face me. We're going to check the balance. Can you balance on, again, your left leg? That's good. Greater than 2 centimeter shifts positive. Now let's balance on the right. And we have a little bit more shift on the right than the left. Now you had a knee surgery, didn't you?
Yeah.
Okay, that's what that's about. Okay, so you sit right here on the edge of the table. So the seated examination is next. The first thing we do is, again, to screen the back. So we're going to check a straight leg raise, make sure it's normal. We're going to check the internal rotation. We're a little diminished on this leg. That's 10 degrees of internal. And we have, 60 degrees, 70 degrees of external. So probably have some decreased femoral anaversion based upon this leg because she has an external foot progression angle. She has some reduced internal rotation and increased external rotation. In the seated position, we always do the basics. We want to check the pulse. She's got a good posterior tibial pulse. We check the DCRs, and they're all normal. Check for sensation. They're here, they're normal. We check for any edema on the lower extremity there as well. So we'll check that. If there's any posterior hip pain, so if there's posterior hip pain, requires a different set of tests, and we always kind of screen for that. So if we, Jane, can you lean way over to the right? So we check on the inside portion of the ischium to see if there's any inside sit pain. If there's hamstring pain, then we would do a hamstring active test at 30. Go ahead and squeeze down. And if that reproduces the pain, we'd want to check the hamstrings. Either the semitendinosus is directly on the ischium, the semimembranosus is to the outside, and that's the more commonly torn. And so we check and compare at 30 degrees, the vector forces pull the semimembranosus into the ischial tunnel and recreate some of the sciatic complaints. So at 90, we'd have her pull in, no recreation of pain. That's a positive test. If the pain is more up toward the piriformis, we do a passive piriformis stretch test in which we adduct and internally rotate to check for the posterior hip pain. We can also do, if there's posterior hip pain, a deep flexion, abduction, external rotation, and monitor the posterior edge of the greater trochanter to make sure that it's not catching the backside of the sciatic nerve. So, okay, let's say you lay all the way back on your back, and we'll go on to the supine exam. Always check the leg lengths. We check a little dial test here to kind of compare for the iliofemoral ligament. They're normal, the leg lengths are normal, so bend both knees all the way up. We're going to start with the Thomas test here. Thomas test is negative. And we do a dynamic internal rotatory impingement. Does that bother you at all?
No.
No? Okay, so I'm okay here. So flexion, adduction, internal rotation. The height in which we go into is dependent upon the sport and the activities. Then we do the dynamic external rotatory impingement, in which we check the outside of the hip and the congruence there. Also, instability will be positive in that position. So we'll come down next. We want to check the abduction. It's got 45 degrees. 25 degrees of adduction. If there's any pain, we check on the adductor, no tenderness on the adductor. And then we always want to screen for the psoas, do a straight leg raise. And the reproduction of the pain anteriorly for the psoas test will be positive for any kind of psoas impingement. And then we bend the knees up, cross the arms across the chest. Any pain in your tummy? No? And do a partial setup for me. And we would just screen the abdomen to make sure there's no fascial hernias in that area. It's important to always check the the abductor. If there's any question of SI joint pain, we want to always check the Patrick Fabreras. And the Patrick Fabreras will be positive to the SI joint if this is positive here, or if we have any pain on the greater trochanter. Can you kind of shoot from the end? And if it's reproduction pain down here, you can also get a strain of either the gluteus medius or even the gluteus minimus anteriorly in this position. But it's also to detect the SI joint pain from anterior joint pain from lateral. So it's important where is the pain in that position. And if there's any pain toward the SI joint, we do a scour and kind of push in on this and monitor the SI joint. And if that's positive, either a posterior rim test in this position or a Galison's, in which you drop the leg off the table. So no need to do that. Okay, let's roll to your left hip. Then in this position, you might want to see here, again, one from that position, we kind of check at the max origin here, distinguish the max origin from the super SI, the ischium, and here's the greater trochanter. We know the posterior facet, the middle facet for the gluteus medius, and the anterior facet for the gluteus minimus, and we check all those three through palpation. Those are not positive. So I next check the strength actively. That's 5 out of 5 for the max. And now we check, release the ITB, lift up. That's the medius, and lift again. That's the minimus. So we check those. If you've got a tear here, you've got reproducible pain and weakness in this area, you're going to have some lateral tearing, possibly the gluteus medius. So if we have, again, posterior hip pain in this position, we do an ischial femoral impingement test in which we bring the hip into extension. And we can take the hip into extension. If it reproduces the pain lateral, that's a positive ischial femoral impingement test. If it's done, if it alleviates the pain in extension by abduction, it takes the lesser trochanter away from the ischium and doesn't recreate the pain into that position right here. That can also be accentuated by short stride or long stride walking. So that's just for patients that present with posterior pain. So then we next do a flexion adduction in this position, because this is a different angle for the lumbar spine than laying flat. This is more functional. We do flexion adduction internal rotation, and we do next a lateral rim impingement here, and then we apply pressure, and that's the apprehension. If we have any kind of instability, that'll reproduce the pain anteriorly. It's really an important test. We come back this way, check the tensor, check the medius, 1+ tight on that one.
I know.
Shoulder back, that's it for the maximus contribution, and you kind of want to know those 3 spots for the contracture for the ITB. So that pretty much takes us through the lateral base examination. Can you roll to Tony? And then we check an Eli's test just to check the rectus. That's a little tight.
It is.
That's a little tight for you. And this is, yeah, that's definitely tighter. And then we'll check the Craig's test. And I think Craig's test is, yeah, and she is retroverted. So there's center for her on this right leg, and it should be this way to center, but she's the opposite. So she does have a retroverted right femur just a little bit on this side. So that's the basic maneuvers we have for, and you can set up there for a second, James. Those are the basic maneuvers.